Endocrinology, we'll see the pathology of endocrine system. We'll start with syndrome of inappropriate antidiuretic hormone secretion. This is page number 338. Characterized by excessive free water retention, euvolumic hyponatremia with continued urinary sodium excretion. Urinary osmolality is always more than serum osmolality. Now, body responds to water retention with decreased aldosterone and increased atrial natriuretic peptide and brain natriuretic peptide. This will increase urinary sodium excretion and normalization of the extracellular fluid volume, euvolumic hyponatremia. Very low serum sodium levels can lead to cerebral edema and seizures. Correct slowly to prevent osmotic demyelination syndrome, formerly called as central pontine myelinosis. Now, what are the causes of SIDH? They include ectopic ADH, small cell lung cancer, CNS disorders or head trauma, pulmonary disease, drugs, example SSRI, carbamazepine, cyclophosphamide. Treatment, fluid restriction. This is the first line. Salt tablets, IV hypertonic saline, diuretics, ADH antagonists like conivaptan or tolvaptan or demiclocycline. Okay, so this is what we see in SIDH. This is important. Urine osmolality more than serum osmolality, hyponatremia and euvolumic hyponatremia. These are the key points to identify SIDH in an exam. Diabetes insipidus, characterized by intense thirst and polyuria with inability to concentrate urine due to lack of ADH. Central or failure to respond responding to circulatory ADH, that is nephrogenic diabetes insipidus. So central diabetes insipidus and nephrogenic diabetes insipidus is there. Etiology यहाँ पे it will be pituitary tumor, autoimmune, trauma, surgery, ischemic encephalopathy, idiopathic. There will be decrease in the ADH. After water deprivation test, more than 50% will increase in urine osmolality only after administration of ADH analog, that is desmopressin. And again the treatment is desmopressin and hydration. Why? Because the kidneys are normal here. So the kidneys will respond and they will increase the urine osmolality. No water, so how do we perform the water deprivation test? Here there is no water intake for 2 to 3 hours, followed by hourly measurement of urine volume and osmolality as well as plasma sodium. Plasma sodium concentration and osmolality. ADH analog desmopressin is administered if serum osmolality is more than 295 or 3 to 300 milliosmoles per kg. Plasma sodium more than 145 or urine osmolality does not rise despite a rise in plasma osmolality. Now nephrogenic diabetes insipidus, the kidneys are gone here. The causes will be hereditary ADH receptor mutation secondary to hypercalcemia or hypokalemia, lithium, demiclocycline, which is ADH antagonist. Here the ADH levels are normal or they might be slightly increased. Urine specific gravity is less than 1.006. Osmolality is less than 300. Serum osmolality more than 290 milliosmoles per kg. Hyperosmotic volume contraction. Minimal change in urine osmolality even after administration of ADH analog. HCTZ, ठीक है, CTZ stimulators, ठीक है, then indomethacin, amiloride, hydration, dietary salt restriction, avoidance of offending agent is used as a treatment in nephrogenic diabetes insipidus. Now we'll see hypopituitarism. This year there is under secretion of pituitary hormones due to non-secreting pituitary adenoma craniopharyngoma. These include Sheehan syndrome, empty sella syndrome, pituitary apoplexy. Sheehan syndrome is ischemic infarct of pituitary following postpartum bleeding and pregnancy. pregnancy-induced pituitary growth. This causes increases susceptibility to hypoperfusion, usually presents with failure to lactate, absent menstruation, cold intolerance, empty sella syndrome, atrophy or compression of pituitary, which lies in the sella turcica. Often idiopathic, common in obese women, associated with idiopathic intracranial hypertension. Pituitary apoplexy, there is sudden hemorrhage of pituitary gland, often in the presence of an existing pituitary adenoma, and usually presents with sudden onset severe headache, visual impairment, example bitemporal hemianopia, diplopia due to cranial nerve 3 palsy, and features of hypopituitarism. There's brain injury, radiation, and treatment include hormone replacement therapy, corticosteroids, thyroxine, sex steroids, human growth hormone. Acromegaly, there will be excessive growth hormone in adults, typically caused by pituitary adenoma. Findings, there will be large tongue with deep furrows and deep voice, large hands and feet, coarsening of facial features with aging, frontal bossing, diaphoresis, excessive sweating, impaired glucose tolerance, insulin resistance, hypertension. There is increased risk of colorectal polyps and cancer. There is increased growth hormone in children and that will cause gigantism, increased linear bone growth. Okay. Then heart failure is the most common cause of death in acromegaly. Again, I'll just repeat this point. There will be large tongue with deep furrows, deep voice, large hands and feet, coarsening of facial features with aging, frontal bossing, diaphoresis, that is excessive sweating, impaired glucose tolerance, insulin resistance, hypertension. There's increased risk of colorectal polyps and cancer. Diagnosis, increased serum IGF-1, insulin growth factor you'll check 1 for acromegaly, failure to suppress serum growth hormone following an oral glucose tolerance test, pituitary mass seen on brain MRI. So these are the 3 tests which we can do to diagnose acromegaly. Treatment, pituitary adenoma resection. If not cured, treat with octreotide, which is a somatostatin analog, pegvisomant, growth hormone receptor antagonist, or dopamine agonist like cabergoline. Now we'll check out hypothyroidism versus hyperthyroidism. We'll read out first hypothyroidism, then hyper, and then we'll compare the two. Hypothyroidism, metabolic, there will be cold intolerance, decreased sweating, weight gain, decreased basal metabolic rate, decreases calorie genesis, hyponatremia due to decrease in the free water clearance. Okay? So BMR is reduced, decreased calorie genesis, decreased free water clearance, decreased sweating, weight gain. Here you can see on the effect on skin and hair. It will be dry, cool skin due to decreased blood flow, coarse, brittle hair, diffuse alopecia, brittle nails, puffy faces and generalized non-pitting edema, myxedema due to increased glycosaminoglycans in the interstitial spaces. This will increase the osmotic pressure and cause water retention. Ocular, you will see periorbital edema. GIT में constipation, decrease in GI motility and decreased appetite. Musculoskeletal, hypothyroid myopathy, proximal weakness, increase in the creatinine kinase, carpal tunnel syndrome, myoedema, which is small lump rising on the surface of a muscle when struck with a hammer. Abnormal uterine bleeding, decreased libido and infertility. There will be hypoactivity, lethargy, fatigue, weakness, depressed mood, decreased reflexes, delayed or slow relaxing. Bradycardia, dyspnea on exertion, decrease in the cardiac output. Okay? Then labs may increase TSH if primary, decrease free T3 and T4, hypercholesterolemia due to decrease in the LDL receptor expression. Okay? So this is important. Hypothyroidism में when it is decrease in the free T3 and T4, that is called as hypothyroidism. and TSH increases if it is primary. Hypercholesterolemia due to decrease in the LDL receptor expression. Hypothyroidism, here there will be metabolically there will be heat intolerance, increased sweating, weight loss. Why? Because there is increased synthesis of sodium potassium ATPase, which will increase basal metabolic rate, which causes calorigenesis. The skin will be warm, moist skin due to vasodilation, fine hair, oncholysis, pretibial myxedema, and Graves' disease. Ophthalmopathy in Graves' disease, including periorbital edema, ophthalmos, lid lag or retraction. There is increased sympathetic stimulation of levator palpebrae superioris and superior tarsal muscles. Hyperdefecation or diarrhea. There is increased GI motility, increased appetite. Thyrotoxic myopathy, proximal weakness, normal creatinine kinase, osteoporosis or increased fracture rate. T3 directly stimulates bone resorption. Effect on reproductive abnormal uterine bleeding, gynecomastia, decreases libido and infertility. There's hyperactivity, restlessness, anxiety, insomnia, fine tremors due to increased beta-adrenergic activity. There's increased reflexes and which are brisk. Cardiovascular system, there will be tachycardia, palpitation, dyspnea, arrhythmia, chest pain and systolic hypertension due to increased number and sensitivity of beta-adrenergic receptors. There is increased expression of cardiac sarcolemmal ATPase and decreased expression of phospholamban. Labs, TSH will decrease if it is primary. Increase free T3 and T4, decrease LDL, HDL and total cholesterol.